about the management of psoriatic arthritis and the current situation with COVID-19 infections. This is my disclosure. My agenda will mainly concerned about the third objective, which is the management, but I give 2 points for introduction about the COVID-19 virus, which is seen as a Janus virus with two phases. One of them is benign phase, and the second is a little bit more lethal and more have a more hospitalization and virulence activity in comparison to the second. And the second point will be about the community of international society with concentration about the EULAR and the ACR guidelines, going to the final objective for the management and local experience. To explore the amount of the scientific work dedicated to COVID-19 infections, if you look today for the clinicaltrial.gov website today and the PubMed Central, you can find that almost 1,050 studies registered as a trial in clinicaltrial.gov and almost over than 6,500 publications already published regarding this topic, which indicates the very high activity among the scientific community regarding the coronavirus infection. As regard our local data in United Arab Emirates for COVID-19, we almost reported our first case in the middle of the February, and right now we have 13,033 cases with 111 deaths with 2,543 patients recovered. Starting from exposure of the coronavirus infection, coronavirus aim to enter inside the cells through the respiratory symptoms, and usually passing to 3 phases until to give the full-blown clinical picture of COVID-19 infection. In the first phase, actually, the delivery to messenger RNA of the coronavirus passed through the cell into 2 common pathways. The first one through binding to ACE2 receptor, and the second one through direct proteolytic activity to the cell membrane to deliver the messenger RNA inside the cells with subsequent replication in the form of vesicles, ending by cell rupture and apoptosis with release of huge amount of the virus. The second response coming to trying to respond and clear the virus through phagocytosis and the expression of the S protein of the virus through the antigen-presenting cells, mainly through HLA class 1 and little bit in class 2. To the T cell receptor, trying to activate the T cell to initiate the immune response against the virus. And there is some reports regarding the different types of HLA. We have almost 4 types of HLA, which is connected to high virulence or high severity of the disease in comparison to some HLA locus or shared epitopes that showing a good prognosis if the patient has these shared epitopes. After T cell activations, the T cell initiates some protective mechanism aimed to clear the virus from the body, which is actually a benign immune response, aiming to direct cytotoxicity through the natural killer cells, which is mediated mainly by interferon gamma, and the activation of cytotoxic T cells to clear the virus, coming to the B cell differentiation to plasma cells, which secretes the antibodies specific to clear the virus. The fourth step, actually, which is responsible for the cytokine storm, which is responsible for the lethal part of the COVID-19 infections. In some situations that we have overexpression, overactivation of T helper 17 with great expressions of chemokines and a group of inflammatory cytokines. So in summary, we have 2 types of scenarios in response to our body to the coronavirus infection. One of them, which is the healthy immune response, which is the good part of the good phase of the coronavirus infection, aim to clear the virus from viremia. And the second one was a dysfunctional immune response associated with cytokine storm, which is connected to many series, maybe connected to strains. Some series will have different strains with different virulence. We have some series about the HLA typing in different populations, and the virus load. If the patient have severe virus load, maybe go directly to this functional immune response, plus the comorbidity in age, sex, and the body mass index. So with the Janus virus of the COVID-19, we have some different phases to the response. One of them, which is the lethal part, connected mainly to cytokine storm, and we don't know which part of of our patient could be suspected to this. It may be connected to the autoimmune conditions or not, may be connected to our medication or not, but this is actually the link between this subject and our presentation today. For the second objective, we have a lot of the International Rheumatology Association response, ranging from Canadian, British, and American, European associations. I will give only 2 slides about the EULAR, which is stated clearly, which one of the first recommendation published from international bodies, that clear advice to the patient: don't stop the medication or reduce the dose unless you get infected. And even in case of infection, you have to revise your medication clearly with the treating rheumatologist, either to decrease or shifting or change the class of medications, plus the advices for social distancing and hand washing and protection techniques. Coming to the last published last week, the ACR recommendations for the management of rheumatic conditions in cases of COVID-19. The ACR COVID task force composed of 14 physicians, 10 of them is expert rheumatologists, and 4 are infectious disease specialists, answer different clinical questions that cover different clinical scenarios in a voting system. There is 4 situations or 4 subjects in recommendation. The first group of recommendation dedicated for all patients, and the second dedicated for old patients with stable diseases. And this recommendation is have 3 different scenarios in case of absence of infection or presence of after exposure of infections and undocumented COVID-19 infection. And group 3, it is a newly diagnosed patient or patient with active rheumatic disease, and the final group of patients for SLE patients. Starting from general statement, the ACR stated clearly that the risk of poor outcome from COVID is usually connected to the associated risk factors and no connections to the disease itself as rheumatic condition or medication used, and highlights that patients should be counseled for social distancing and avoid healthcare contact through decreased frequency of lab monitoring and the virtual clinic and telemedicine. And for corticosteroids, it is safe to be initiated and at the lowest dose if needed, and it shouldn't be stopped abruptly. And also for the treatment with ACE inhibitor or ARBs inhibitor could be used safely and initiated if indicated in our patients. For the second group of recommendation, which is dedicated for patients with stable disease diagnosed before the onset of COVID-19, we have 3 different scenarios, either in absence of infection or following exposure and following documented infection. In case of absence of infection, this patient usually treated as usual with continuous conventional DMARDs or biologics and even JAK inhibitors or NSAIDs to be continued. For treatment, long-acting medication like denosumab also can be given or can increase the space up to 8 months just to decrease the contacts between the patient and the hospital. And for patient with history of vital or organ-threatening rheumatic condition, the treatment should be continued as the same dose without any reduction of the treatment dose. In case of exposure to the virus before confirmation of infection, patient continue hydroxychloroquine and cilazopyrene, but you have to quit the non-interleukin-6 biologics and JAK inhibitors and other immunosuppressive until we get negative COVID-19 testing negative. And the panel have actually controversy about the continuation of doflunomide or methotrexate, either to continue or stop. And as regard for interleukin-6 blocker, in some situation, we can continue based on a shared decision and individual assessment for each patient. For a stable patient with documented infection, patient have to quit all medication except hydroxychloroquine and steroids, and especially for patients with immunosuppressives. And in case of respiratory distress syndrome, patient also have to quit even the non-steroids. Also, in selected circumstances, patients have maybe continued interleukin-6 inhibitor based on individual assessment and shared decision in each cases. And the panel have actually uncertain situation regarding the continuation of JAK inhibitors. For new diagnosed cases, in case of absence of infection, patients start with hydroxychloroquine and showing if it is responding well to hydroxychloroquine, he can continue and add different conventional DMARDs like methotrexate or leflunomide. And for initiation of the biologics, it's favoring of the patient for interleukin-6 inhibitor, and if the patient not controlled, we can shift to another biologic, and still they are uncertain about the position of JAK inhibitor in these situations, and we can shift between even different mechanism of actions in conventional DMARD and biologics. In case of newly diagnosed patients that have confirmed infections, patient also treated as old patient stable with the same schematic algorithm mentioned before. And finally, for SLE patients, continue for hydroxychloroquine, and in some situation we can initiate belimumab for controlling the disease. Going to the PSA management in COVID-19, actually, which is covered by Professor Peter and Professor Yasser. We have two important points in our patient with PSA in the right situation, which is about the patient risk stratification. Are our patient with psoriasis at a higher risk of infection in comparison to other patients? And the second point are our medications increase the risk of poor prognosis among patients with COVID-19 infections or not. It is known that psoriatic arthritis or psoriasis itself have a high prevalence of association between metabolic syndrome, hyperlipidemia, hypertension, insulin-resistant diabetes, and obesity. This has been confirmed in many trials, and this paper published in 2013 showing a systematic review of cardiovascular comorbidities in patients with psoriasis and psoriatic arthritis, and showing a high prevalence in dyslipidemia, body mass index, obesity, diabetes, hypertension among patients in comparison to patient control subjects, which means that by some means that patients with psoriatic arthritis have a high prevalence of comorbidity, which may increase the risk of poor outcome from COVID-19 infections. Going to the medications, as Professor Yasser said, we have almost 11 approved in GCC region, and almost international, we have 13 molecules from 2002 to 2019, which is approved for the management of psoriatic arthritis. But in the current emergency situation, we don't have any evidence-based data showing the safety and the preference of mechanism of action over the others. We just rely on our experience and some reports which can support our clinical decision. And as we've seen on all recommendations mentioned in the previous two lectures and also in the ACR recommendations, there is no preference between different mechanisms of actions except interleukin-6 blockers. But I will show only two sets of data coming to support the safety of interleukin anti-cytokine therapy and biologic in general in the management of psoriatic arthritis, and could help in the current situation. One of them is published in Annals of Rheumatic Disease in December 2018, which is epidemiological data showing comparative risk of serious infections among real-world users of biologics in psoriasis and psoriatic arthritis. They assemble a retrospective cohort of patients have psoriatic arthritis treated from the period of 2015 to 18, and they try to compare the serious infection risk between these two groups, defined by any infections that require hospitalization after the biologic initiation. Interesting is that in this group of patients, along with this 3 years, we have almost 11,560 episodes of treatment, and serious infection rate was almost happens 190 serious infections only in these episodes, which means a very low prevalence of serious infection, which gave a trust actually among this kind of medications. It was including interleukin-17 blockers, TNF inhibitors, and Stelara. And among them, there was no significant difference regarding the serious infection risk in interleukin-17 and TNF inhibitors. But for Stelara, it was significantly lower in comparison to the two mechanisms of actions. The second set of data coming actually published 2 days back in New England Journal of Medicine, showing a case series published from the New York showing patients case series with different inflammatory conditions from rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and IBD. And this patient was confirmed to have COVID-19 infections. And for analysis of this patient, 72% was treated with biologics and JAK inhibitors, and the overall incidence of hospitalization was almost 16%. And if you compare this hospitalization incidence in comparison to general population, it's almost comparable, almost the same. So there is no significant, if you can extrapolate this result to others, there is no increased hospitalization risk between patient with rheumatic condition under biologics to others. And in the patient who are hospitalized in this cohort of patients have a higher percent of comorbidity like diabetes, hypertension, and COPD, and most of them are older than the patient who are ambulatory, which is also matched the hospitalization risk in general populations. Coming to the value of or effect of biologics, which is expected to increase the severity of infections. Actually, the result coming on the reverse, as we can compare the ambulatory patients who is treated as an outpatient or treated with just home isolation in comparison to patients who are needs hospitalization and oxygen-dependent therapy. 76% of patients who are ambulatory are under treatment of biologics or JAK inhibitors in comparison to patients who are as hospitalized, are 50% of them are in biologics and JAK inhibitor, which at least give us safety signals for our patient treated with biologics. As regards the characteristic of patient, you can see different diagnoses from psoriasis, psoriatic arthritis, rheumatoid arthritis, and IBD, and ankylosing spondylitis. And most of patients admitted was treated under the treatment of rheumatoid arthritis. And if you look to the different classes of medications used from conventional DMARD to anti-cytokine or small molecules, you can see here, as we said before, that patients with ambulatory patients have almost a higher percent of biologic treatment, or almost 76%, in comparison to patients who are hospitalized. Only 50% of them are using biologics and JAK inhibitors. And also for the second point, which is mentioned about medication with longer duration of actions, like interleukin-23 blockers and interleukin-12-23 blockers, which almost last for over 3 months, you can see that 0% of them need hospitalization, which also give us a safety signal regarding this class of medication. Unless they are acting for a long time, this patient infected and still ambulatory and don't need hospitalization. And for the final prognosis of these patients, only 1 patient of them needs ICU-dependent ventilation, and this occurs only in 1 patient with 7% ratio. Coming to the local experience, I revised my files for the last 3 months. I have initiation almost for 3 cases since the start of COVID-19 in December 2019. 2 of them male and 1 female. 1 started in December 2019, and the other 2 cases started in early February. And thanks God, till today, I don't have any infection among my patients. This patient, a female patient, 42 years old, with psoriasis for 1 year. She's presented with a heavy psoriatic lesion affecting her scalp with extensive scales, hands and sole and feet, also scaly lesions. We have 2 finger and 2 index finger of both sides are swollen, with bilateral hand heel finger pain lasting for the last 3 months, with no associated reported cardiovascular or diabetes comorbidity. And she described her VAS as 8. Her clinical assessment showing DIB arthritis symmetrical with tender joint count about 10, swelling joint count 4, with bilateral fasciitis of both heel, dactylitis of both index finger, palmoplantar psoriasis, and scalp psoriasis. Her inflammatory markers wasn't normal for ESR and CRB, but their assessment score for her joints showing high activity for the CDI, SDI, and DAS-CRB and DAS-ESR. For ultrasound assessment, I'm doing for all my patient assessments with ultrasound. This is actually ultrasound assessment of index finger using longitudinal scan. We can see that there is almost a significant edema of subcutaneous tissue, showing hypoechoic spots denoting inflammation of subcutaneous tissues, with distension of the tendon bolus, which appears as black shadows here. This distension indicates the inflammation of the paratendon or tendon covering, with slight inflammation of the joints here. And the other figure here, we can see the Doppler signal that showing increased Doppler activity in the subcutaneous tissues and the paratendon, especially around the tendon bolus. This is a typical picture of dactylitis seen by ultrasound. For assessment of the heel, we can see here, this is the inferior surface of the calcaneus, showing the attachments of the plantar fascia, which appear to be edematous with increased thickness and a thin layer here of hypoechoic patches, black patches here, indicates edema and thickening of the plantar fascia in case of active or acute plantar fasciitis. The patient at that assessment, she was on methotrexate 20 milligram once a week, NSAIDs and topical treatment, and the action done that reducing methotrexate to 10 milligram and start to escalate Stelara, 90 milligram given at week 0, and after 4 weeks, she took only 2 doses till now. Topical treatment, 1 Demonidrol shot and continue non-steroidal. This patient actually followed on virtual clinic because in the second dose time she was in the lockdown in Dubai. So I just phoned her and get a call, a visual call with her. She reported that her pain almost improved by 50%, going past to 4, and skin scales improved for almost 50%, and the pain and the swelling in her fingers connected to dactylitis is also improved. This is my second case, which is initiated mainly in early of December. This is a male patient from South Africa. He's 35 years with polyarticular psoriatic arthritis for 3 years, presented with bilateral wrist, bilateral second, third MCPs, and second, third, fifth BIB and DIBs, dactylitis for the foot, left fourth toe and right first toe, bilateral Achilles tendonitis, and small red scale lesion in both elbows and knees, and the VAS. Actually, this patient have a little bit, very little skin psoriasis, but have a very aggressive, I will present later, lesions along his joints and incisions. His labs CRB is significantly positive, and ESR also, with activity scores very high, CDI, SDI, and that's CRB. His ultrasound, this is a longitudinal assessment of the wrist and dorsal scan. We can see an active synovitis, which is appeared as black shadow intra-articular here, with significant Doppler signal classified as grade 2 Doppler signal positive. And for assessment, this is the left fourth toe showing fusiform swelling of dactylitis, which is the commonest place to have a dactylitis in the lower toe, according to the Toronto cohort. We can see there is distension of the subcutaneous tissue with hypoechogenicity, with increased Doppler signal surrounding the paratenon and subcutaneous fat, with very little or distension of the MTB joint. It's a typical picture of dactylitis of the fourth toe. And for the Achilles tendon, this is a posterior longitudinal assessment of the Achilles tendon. We have this is a posterior surface of the calcaneus. You can see a very big, huge step down abnormality, cortical break, indicating an erosion of the posterior surface of the calcaneus, with distension of the Achilles tendon, but the Achilles tendon is still normal fiber pattern, but we have a little bit signal of Doppler at the paratenon from posterior and inside the tendon also, with distension of the sub-Achilles bursa with thickening indicated chronic bursitis. It's a typical picture of acute tendon Achilles inflammation on top of chronic lesion due to the presence of erosions and chronic synovitis of the sub-Achilles bursa. The patient was under treatment for methotrexate 20 milligram once a week with folic acid and NSAIDs for the last 3 months before this assessment. He initiated started with Stelara at dose 90 milligram. He got 3 doses, 0, 4, and 14. Methotrexate went down to 10 milligram, and he take 5 milligram steroid once a day. This is a follow-up after 3 months. You have only 1 tender joint at rest, CRB normalized to normal. You have cleared the enthesitis, cleared dactylitis, and the clear skin. Well, assessment score going down to remissions, either CDI, SDI, DAS, CRB, and DAS ESR. This is interestingly the ultrasound picture. If you can compare, this is before starting the treatment, and this is after. The total disappearance of the Doppler signal between the 2 lesions. We don't have Doppler signal inside the joint at all, but still we have the grayscale changes. So actually it takes time to change, but the good response usually measured in short term by disappearance of Doppler signal from the intra-articular synovitis. And for assessment, we can see there is improvement of the clearance of dactylitis with disappearance of the signal that was present around the extensor expansion tendons of the fourth toe. And for the Achilles tendon, Still, we have the chronic lesion at the erosion, which actually will not disappear by the medication, but we can see there is recession or decrease in the size of the sub-Achilles bursa and decrease of the number of Doppler signal inside the tendon. Still, we have little bit inflammation of the paratendon that is still present, which they get a good response to the medication. My home messages that COVID-19 infection and hospitalization rate still comparable in patients with rheumatic disease to the general population. We don't have any signals showing that we have increased hospitalization among our patients in comparison to general populations. And the high-risk group of the patient under COVID infection is still connected to the associated general comorbidity rather than to the rheumatological condition and even the medication used, as we shown with different case series and scenarios. Until today, there is no evident data alarming continuation of immunomodulator or biologics in non-infected patients or favoring even one mechanism over the other based on the data that we have. This is my references, and thank you.
Dr. Ahmed, thank you very much. Very efficient.